So welcome, Dr. Utsav. So we were discussing regarding the indications of the barrage lasers. So the symptomatic peripheral retinal degeneration and the horseshoe tears, and the regarding the holes and lattice degeneration below the age of 15 years. So now we will be discussing about the lattice degenerations, PRP, and the complications. So what is a lattice degeneration? It is mostly just like I will explain with the help of a picture. It is like a circumferentially oriented cigar-shaped areas of retinal thinning, pigmentation, or whitening. So what happens is the vitreous is very adherent to these edges. So while doing laser, if you remember, I told that the laser should be away from the lattice. It should not fall on the lattice, because the lattice, the vitreous is very adherent. If it falls on the lattice, so what happens when the laser scars forms? It contracts, and that contraction, the vitreous is very adherent there, so the traction can increase, and the laser itself can induce the traction and cause rhematogenous retinal detachments. And almost 40% of this lattice, yesterday only, day before yesterday, sorry, I saw one case of lattice and snowflake degeneration, but with atrophic holes, and option of observation to the patient. Now what happens practically, we should always give an option of observation to the or the prophylactic barrage laser to the patient, but sometimes, as sir said, the first option, the first case, the patient becomes lost to follow up. So always give an option of prophylactic barrage laser. Prophylactic word is very important, because here the 6 months they won't follow up unless and until there are symptoms. They would forget, and so they can land up in retinal detachment. So this we discussed, and one more point, what is subclinical? We have seen 2-3 young patients also, irrespective of the age, below 13-14 years of age, with subclinical retinal detachment. So subclinical retinal detachment, there is no particular definition to it. It is just anterior to the ora. It is the subretinal fluid around this thing, 1 to 2 disc diameters, just anterior to the ora, the subclinical fluid, which is till the equator. So that is the subclinical retinal detachment. Anything which is beyond arcade, we can laser. If there is a subclinical retinal detachment beyond arcade, we can stop the progression by laser. So family history, there's one more thing, there's called as atypical lattice, that is the radial and the perivascular or the paravascular lattice. We should laser them, and because it has a high risk of retinal detachment, and prior to any refractive or cataract surgery, we should plan a barrage laser before there is any intraocular surgery. Now we will in the further slides we will see the difficult situations, how to manage them. So these are the barrage laser parameters, the spot size and the power. So what is the most important is the grade of the burns. In further slides, we will come to know the about the grade of the burns. So, I want to ask Dr. Utsav any opinion regarding the grade of the burns. What should we aim at the barrage laser?
So, particularly, there are 4 grades of the burn, and we should aim at second degree.
Yeah.
So,
okay.
Just grayish coloration should come. Because after that it will be chalky white burn, and it can cause traction, and it can cause choroidal effusion also. So we should prevent that.
Right. So the grade of the burn is, grade 1 is, so I might have so these are the grade of the burn. So the grade 1 is the just visible burn, and grade 2 is a yellowish burn, grade 3 is yellowish to grayish, and grade 4 is chalky white burns. Then the grade 5 and the grade 6 is, we do not see those, but we should avoid grade 4 burns. Grade 2 to 3 we should aim at. So grade in particularly barrage and pan-retinal photocoagulation. So the grade 2 to 3 we should aim at those burns. Grade 1 is for the focal lasers in non-center involving diabetic macular edema and non-resolving CSR, FFA guided. So but grade 2 to 3 we should aim at. Now coming back to the spot size, power, and the duration. So it all the power and the duration. Power depends on the media opacity. Suppose we have a young patient with a clear lens, so even at 30 to 40 milliwatt power, we can get a grade 2 to 3 burns. If we have a elderly patient with a dense cataract, so even if we increase the power like to 200 to 3, we can increase till 250 to 300, then we can get a grade 2 to 3 burns. It all depends on the media opacity, the power. The duration should be around 100 milliseconds to 200 milliseconds, depending on the contact lenses in the slit lamp we are using. So we are using the two lenses, we'll come to know. So what is the mechanism of the barrage laser? So barrage laser, it creates a small controlled thermal burn surrounding those retinal tears. This causes a barrier. This is called as this causes a barrier. It which acts as a that prevents the vitreous fluid migration in the subretinal seepage. So the RP and the choroid becomes adherent due to the formation of the scar, and then it acts as a barrier. Similar to the acts as a when we explain to the patient to prevent the flooding from the dam is there, that barrage is there. So similar to that, we create a barrage lasers. So always remember 2 to 3 continuous rows of barrage laser should be there to prevent the retinal detachment around 0.5 to 1 disc diameters away from the lesion. In cases of horseshoe tears or subclinical RD or a shallow retinal detachment, we can do barrage very close to the RD because we want to prevent the progression of that retinal detachment. So what is the procedure? So we, as we all know, we counsel the patient regarding the barrage lasers, and this is to prevent the retinal detachment, but we counsel the patient ki why are we doing the barrage lasers, and it's not related with their refraction or any vision. And then we dilate the pupil with an appropriate tropicacil plus tropicamide drops, and then we check for the slit lamp alignment also, and we uses a vertical slit beam and narrow and short as possible. And now in our a slit lamp machine we have magnification. So what we use is the 0.6x the lower magnification and the 100 spot size with a 100 millisecond duration. So in the beginning as a beginner, if you are comfortable, then you can use 150 millisecond duration also with a 10x magnification with a 200 spot size. Spot magnification factor also changes with these lenses. So these are the grade of the burns, and also these we get that post silicone oil filled globe. If we want to do an augmentation of the laser, so what they say is artificially it increases the power, it increases the spot size, and prevents the heat dissipation. So in oil filled eye and gas filled eye, we should titrate the power accordingly. So what after the laser, so no, I had some scenarios. Yeah, so I wanted to discuss these scenarios. So this is the scenario one. So I want to ask Dr. Chanchal, so if you have this kind of a scenario with a pigmented lattice which is undergoing the barrage lasers, and so what is shown in the right hand side is the photo of the barrage laser already being done. So what is your opinion regarding this barrage laser?
The barrage doesn't seem to be continuous. There are spaces in between the laser marks. So I think this patient needs a barrage again, so that we fill all the spaces which are missing. Otherwise, tear will increase from that side, from where the barrages are not done. So the barrage is not proper in this case.
So the distance of the laser mark from the lattice is very close. So we should not be very close to the lattice, because if we are very close to the lattice, as the laser marks contracts, the traction can increase, because as we say, the vitreous is very adherent to that lattice. So the distance should be around 0.5 to 1 disc diameter away from the lattice, and as Dr. Chanchal mentioned, that it should be a continuous 2 to 3 rows of the barrage laser. So now suppose we have a second second scenario. So Dr. Lalita, so can you tell me like how to barrage these, and what is the right hand is the 1 month post picture of the barrage laser? Is it okay? And this is the right hand side, the post burn. So so like post barrage laser after 1 month. So these are the scar marks they are forming. So they are the black scar marks they are forming, and these are the good barrage. They are nicely like covered barrage. The distance is also fine. The barrage laser marks it's also continuous. Like those small spaces you are seeing, that those are the little artifacts, but otherwise it is the continuous barrage. So now the scenario third. So now we have multiple lattices here now, and some lattices are very anterior also. Now in anterior part, if you can see the pointer is not there, but the anterior part there is no space to cover those lesions. So how to go about it in this scenario? And
first we start in the posterior margin like every lattice, and if we can't see the aura, we need to attach to the aura so that it will be anchored correctly, since we can't see the anterior margin of the lattice.
yes, so nicely mentioned. So Dr. Akriti, you understood that we should start with the posterior margin first, because posterior margin, as we go anterior, the retina is thinner. So we start with the posterior margin first, because the patient is also comfortable there when the retina is thinner. So when we place the laser, there can be chances of pain also. The patient feels a little discomfort also. So we go posteriorly, 0.5 to 1 diameter away from the lattice. We cover the posterior margin first on the slit lamp, and with 2 to 3 rows. 2 rows is sufficient in young patients. In elderly, around with vitreous degenerations, and 2 to 3 rows with the posterior border first, and then with the LIO with a scleral indentation, we could join the aura. First we try to cover the anterior border at least 2 rows, cover the anterior border. If it is not possible, if the space is not there, or suppose the IOL edge is precluding that, or there's a dense cataract, or there's a non-dilating pupil, then we indent and we connect to the laser marks to the aura. Okay. Now in this case, they have individually described the barrage laser for the individual lattices. If it is possible to, now there are multiple lattices, if it is possible to individually laser that, then well and good. Otherwise we can cover the whole and we can connect to the aura, but as whenever possible, do it individually first. So now, what are the causes of a retinal detachment in a previously barraged lattices? So the most important is the anterior border is not properly barraged. Sometimes the tears may develop at the anterior margin of the lattice. So if the anterior border is not properly barraged and the tears develop, then we can develop the retinal detachment. So what are the special situations, the pediatric age group, as we talked about, if they have a retinal tear or a horseshoe tears, and they may not cooperate for scleral indentation, particularly for anterior lattices, we can do them under short GA or sedation. And in pseudophakic patients, what happens, the IOL edge, when the lattice or the hole is very anterior, the IOL edge, if we do a barrage laser, the laser might diffract from the IOL edge, so that anterior margin is not possible. So in that cases, in rare cases, we can consider cryotherapy. In dense cataract, we had one-eyed patient with a dense cataract with a lattice with holes. So we had to do a cryo before the cataract surgery, because the patient was not very cooperative also, and had the dense cataract was also preventing the laser to fall on the retina. So yeah.
In that case, first we can't do the dense cataract surgery, afterward we can do
Yeah, because even I thought that, yeah, very nice question, but it was a lattice with this thing. I think two holes were there. So we were, and already she was a one-eyed patient. So we thought of, to be like on the safer side, on like to first do the cryotherapy and then do the cataract surgery. If it's a dense cataract with a lattice, pigmented lattice with no symptoms, then we always we can do the cataract surgery, and after 2 weeks we can do the laser easily. Now, any questions regarding the Barrage? So, like we had one patient, very uncooperative patient. So, I mean, the special situations are like non-dilating pupil, the Marfan syndrome, the IOL dislocation, superior lens dislocation is there, and then the young patients, we had very sensitive patient she was very anxious. So sometimes even like my fellow was there, so I became the patient and I told my fellow to put the lens on me so that nothing will happen. So you have to explain by becoming the patient also. So these cases we have to counsel the patient properly. So we are doing this Barrage and to prevent the further retinal detachment. Yeah, this pseudoexfoliation, non-dilating pupil, and the Marfan syndrome, these are the difficult cases, and this non-cooperative. Many times in the non-cooperative patients, we have done Barrage laser under peribulbar block also, like 2-3 times under peribulbar block also, particularly the anterior margin of the laser. Now, coming to the pan-retinal photocoagulation, so Dr. Akriti, I want to ask what are the indications of pan-retinal photocoagulations? In which patients would you advise pan-retinal photocoagulation?
In the cases of diabetic macular edema, we advise the first anti-VEGF, after that pan-retinal, or PDRs, we will advise the pan-retinal coagulation, or not responding BRVOs or CRVOs to the anti-VEGF injections, or choroid CSCR.
Pan-retinal coagulation, always remember, if there is any evidence of neovascularization, whether it's in the iris, disc, or elsewhere, or angle. So NVI, NVA, NVD, NVE, whether there's any evidence, then the first management is your pan-retinal photocoagulation. So we have seen cases of proliferated diabetic retinopathy with with or without diabetic macular edema. So when there is a PDR with diabetic macular edema, we do pan-retinal photocoagulation plus an anti-VEGF injection. So what we do here is the first sitting we do it in the OPD, and then take the patient to OT and do an anti-VEGF injection. The anti-VEGF injection and the pan-retinal photocoagulation, the gap should not be more. If the patient is just willing for one procedure only, then give an anti-VEGF first, then you can call, depending on the severity of the PDR, you can call the patient again for the pan-retinal photocoagulation. Okay, so these are, so in single spot, what we can use is with a higher magnification with the contact lenses, the Mainster PRP and the Vogue Supra Quad lenses, we can do with a 200 milliseconds 200 power and a 200 spot size we can use. Power depends on the grade of the burns. Again, the grade of the burn used is grade 2 to 3 burns. So this is the pain area. So what I wanted to show is that the multi-spot delivery, in how do you start the pan-retinal photocoagulation laser. So in cases of vein occlusion, always do the laser till the aura. So what are the sittings in the first sitting? So Dr. Chanchal, can you elaborate in first sitting what we do here, in which quadrant we do?
We usually do supranasal and the nasal part, and in the second sitting we do infratemporal, and whatever the remaining part of the first sitting, and on the temporal side, very away from the away from the arcade, right?
I think it should be done in the lower half of the retina first. There is a chance of vitreous hemorrhage. if there is a vitreous hemorrhage, we cannot do laser therapy in lower retina.
Yes, sir. As very rightly said by Dr. S.K. Gupta, sir, that inferior part and should be done first, because if there is a vitreous hemorrhage in later on, then we cannot do the laser in the inferior part. So what we do here is the inferior quadrant. The first sitting we do the infero-nasal part, and the second sitting we do the full supero-nasal part, and the third sitting we do the temporal part. That the distance between the disc and the macula, the same distance we keep from the macula to the temporal area. What is the mechanism of action for the laser? How does the PRP acts? So how does the PRP acts? Any mechanism? The theoretical mechanism that decreases the oxygen demand and converts the hypoxic to anoxic areas. So now most important thing is this the lasers, pan-retinal photocoagulation, so should be avoided in cases of, like I mean to say, if there is any traction, particularly the elevated NV or a fibrovascular proliferation, then we should do it at the edge of the traction. We should measure from the 2 disc diameters away from the traction, and when we should start the PRP there. And even in the beginning, we should always take a standby mode and always measure the disc diameter and then go nasally. Now in the slit lamp, through the view, always remember it is inverted as we see in the 90D. So it is temporal is nasal. So go temporally and do 2 disc diameters, 1 to 2 disc diameters. You can do the laser in the nasal area. Okay, and from the disc also superiorly and inferiorly, you can do 2 disc diameters away from that. You can do the PRP through the view superiorly and through the view inferiorly. I mean the infero-nasal in the first setting. So it will be through the view superotemporal. Okay, and from the arcade you can go close to the arcade, but in the first sitting I go little away from the arcade, around 1 to 2 disc diameters away from the arcade. In the second sitting I go close to the arcade, and in the third sitting temporally from the disc to the macula, whatever the distance is from the disc to from the macula to the temporal quadrant. Now always remember the distance from the macula also. The laser marks should be from the arcade, like from the macula it should be 2 to disc diameters away from the macula, superiorly, inferiorly and temporally, because sometimes there is a blood vessel between and the arcade also, so do not confuse that blood vessel with the arcade. So these are the indications of the high risk PDR or any PDR. We do a pan-retinal photocoagulation, ischemic CRVOs or CRVO with neovascular glaucoma. Now most cases of neovascular glaucoma, we have a non-dilating pupil. So in cases of those non-dilating pupils, we do a PRP to the extent possible, and always do a anti-VEGF treatment with a paracentesis also, along with in addition to pan-retinal photocoagulation. So whenever you cannot supplement the PRP, suppose there's a corneal opacity is there, or any media opacity precluding the laser area, then you can supplement those PRP with an anti-VEGF. Okay, and suppose if there's one eye is severe NPDR and other eye is PDR, do a laser to both the PRP. You can advise to both the eyes.
We should give intravitreal first, or we should do PRP first in that scenario?
So if the patient is willing for the in which scenario?
This NVG.
NVG. So in NVG we should reduce the pressure, and we should if the patient is willing for both the things, we can do the first sitting in the OPD, and then we can take the patient to OT and do anti-VEGF plus paracentesis. If he is willing for one procedure only, then anti-VEGF should be given first, because sometimes the risk or the side effect of the pan-retinal photocoagulation is a reactionary macular edema. So it is always advisable to do pan-retinal photocoagulation under the cover of anti-VEGF. So the zones to avoid during PRP is major blood vessels, chorioretinal scars, fibrovascular proliferation, and the elevated NVs. Over the flat NV, you can do we should do the pan-retinal photocoagulation, and always remember the 12th 6, 3 and 9 o'clock meridians, there are the ciliary nerves are there, so the pain perception is more. So what you do practically is you can decrease the duration. If you are doing the duration at around 100 milliseconds on these meridians, you can decrease the duration till around 80 milliseconds, keeping the power same. So the pain perception is less. And whenever you are going in the slit lamp, the anteriorly do a retro illumination, so you can see the your laser beam quite well focused. If you are doing at the like posterior till the equator, the illumination can be around the beam can be around the oblique illumination. Okay. So these are again the indications, the NVI, NVA, NVD. So these are we should avoid these areas. So the takeaway is identify the lesions which are very important in these cases is the decision making, when to observe, when to treat. So suppose sometimes the snail track degeneration, it is looks like it is a lattice with holes. Sometimes it's difficult to differentiate between the two. So differentiate between the two and counsel the patient. If it is the patient is asymptomatic, we can very well observe, but always counsel the patient regarding the symptoms, so they are not lost to follow up if you want to observe. And the laser should be 2 to 3 continuous rows. There should not be any gaps. There should not be any close to the lattice, or the anterior margin should be properly lasered, because most of the retinal detachment in a pre-existing lasered barrage patient, because of the retinal tear at the anterior margin, it happens through those new breaks. Avoid the area of the traction. It should be 2 to 3 disc diameters away from the traction. In the pan-retinal photocoagulation, again the same principle, but see the distance from the disc and the macula, and from the elevated NV, the traction, the major vessels, and the 3, 6, 9, 12 o'clock. Remember to decrease the duration. In pan-retinal photocoagulation, explain about the peripheral visual field loss if the patient is driving, and the follow-up. I follow up generally after 6 weeks. After 6 weeks of the complete pan-retinal photocoagulation, we should see for the regression of the new vascularization. If the new vascularization is regressed, then our pan-retinal photocoagulation is complete. So there are no particular settings for the pan-retinal photocoagulation. Whenever there is an NVE, we need to augment these pan-retinal photocoagulation. So now suppose if we do a pan-retinal photocoagulation, I call the patient after 6 weeks. If there is still an NV present, we should augment those PDR patients, those pan-retinal photocoagulation. And if there is a vitreous hemorrhage, the vitreous hemorrhage can happen due to 2 things. Either it is a PVD induced, or there is an NV which is not regressed, which has bleeding. So always augment those cases also. If we the better to do is an FFA to find the cause, whether it's a PVD induced or an unregressed NVA. So and always so these are the takeaway points for the pan-retinal photocoagulation and the barrage lasers. Over the flat NV, we can always do we should do the laser over the flat NV. And suppose if there is no traction, if there are multiple NVs you can see, and there is a PDR, then you always do a double therapy, in the sense that you do an anti-VEGF plus a pan-retinal photocoagulation. In those cases, if there are multiple NVs, without any center involving diabetic macular edema on OCT. And the one more important point of regarding the focal laser as well. Focal laser is used in still has a role in non-center involving diabetic macular edema, where the center is not involved. There is a cercinate retinopathy, and there is a microaneurysm which is leaking. So you can always do a focal laser to that. How to do a focal laser? you take your laser to the periphery, like lower the power, because the focal laser, the grade should be grade 1, just visible burn. So you titrate in the periphery, it should be just visible. If it is coming at grade 2 in the periphery, then lower the power and the duration, and then you can, if it is just visible, then you can do the focal laser at the microaneurysm. Similarly, in non-resolving CSR, FFA guided focal laser to the area of the leak you can do. So what you do is, when we do an FFA, you take the area of the leak and you take a printout of that, you take a zoom in printout of that area. So where the vessel is, where the leak is, and you can do the focal laser around that area. So actually we have to just stimulate the RP so that the fluid resolves, the leak resolves. Yes. So thank you. These are my references. Any questions are most welcome. Yeah.
In case of severe or a very severe NPDR where you can't see neovascularization, so in that case it will be conundrum that whether to do PRP or just give anti-VEGF. So in these cases, what should we do?
So, a very valid question. We face this dilemma day in and day out. Like when we don't have an fundus fluorescein angiography, and when an FFA is available, then it becomes an easy. So, in cases of very severe NPDR, or in cases of NPDR with even with asteroid hyalosis, it becomes a dilemma. So, when the FFA is there, we can find out the NVEs. When there is no FFA, very severe NPDR, we can always advise a prophylactic Barrage laser, Pan-Retinal photocoagulation to prevent the further management, and always see whether the patient is on insulin. What I have seen is when the patient is on insulin, or second thing is type 1 diabetes mellitus, so they have a very fast progression to a PDR cases. So they keep this factor in mind, and also the metabolic parameters, the nephropathy status. Okay, so keep these parameters in mind. So if these parameters are present, then you can advise pan-retinal photocoagulation.
What are the criteria in FFA?
Yeah.
For PRP.
So FFA, it is very simple, because in the FFA, even if you see a single NVA, you should do a full PRP. Okay. So FFA in cases of vein occlusion, so if you see a greater than 10 disc areas of capillary non-perfusion areas, you can do a PRP. So what the studies state, that evidence states that any evidence of neovascularization clinically, or on if you're not visible clinically, or on FFA it is visible, then do a PRP. If it cases of ischemic CRVOs, ischemic whether more capillary non-perfusion areas, you can do a prophylactic PRP, because there's a risk of formation of neovascularization over there. In vein occlusions, do till the ora. And in kidney patients, like the patients having high creatinine levels, always space the PRP in 3 to 4 settings, because of the risk of probability of choroidal effusions there. Yeah. Yes, sir.
We are using pilocarpine in presbyopia nowadays. Is it contraindicated in peripheral retinal disease?
Sorry, pilocarpine?
We are using pilocarpine for presbyopia nowadays.
Yes.
Is it contraindicated in peripheral retinal disease?
Okay. Yeah. Very nice question, because this pilocarpine drops have been come for presbyopia, na sir. So yeah, for this peripheral retinal degeneration, the sir is asking that should we not use in those cases so that periphery we cannot see, na periphery. For the examination. Yes. A very nice point. Yeah, very nice points to ponder. Yes, I think, sir, I'll search the literature more on this, but I think we should avoid in those cases, because otherwise we cannot see the periphery in this. Yes. Nice. Thank you.